Good morning. Welcome to today's explainer for our teaching rounds. I'm the senior resident on service, and I want to walk you through 6 high-stakes clinical cases we're managing right now regarding gastrointestinal motility and nutrition. We aren't just going to list off symptoms here. I want us to really break down the underlying pathophysiology, look at the exact data we need, and detail the precise management steps we're taking for each of these patients.
Okay, so here is our roadmap for this service today. We'll start out with a case on the gut-brain axis and IBS. Then we'll move on to some upper GI issues, specifically cyclic vomiting and gastroparesis. After that, I want to spend some real time on a critical case of acute colonic pseudo-obstruction that I was called about overnight. Then we've got a structured approach to a constipation case, and finally we'll head up to the ICU to talk nutrition and critical illness. Let's get to it.
All right, starting with Section 1, the gut-brain axis and IBS. This is our first patient on the ward.
So we have a 28-year-old woman. She's got an 8-month history of lower abdominal cramping. The pain consistently eases after she defecates, but her stool form has been alternating wildly. We checked her labs and celiac serologies, and everything is totally normal. So we're dealing with a functional GI disorder here. The bowel itself isn't structurally broken. Rather, the signaling loop between the enteric and central nervous systems is misfiring, meaning normal gut activity is being perceived as pain. As you've taught us, the most important therapeutic step is how we frame this to the patient. I made sure to tell her, your gut and your brain are miscommunicating. This is a real, treatable condition.
Looking at her history, she perfectly meets the strict Rome-4 criteria for irritable bowel syndrome. She's had this pain for well over 6 months, and it's associated with both symptom relief upon defecation and a distinct change in stool form. I think it's crucial to remember that IBS is a positive clinical diagnosis. It's not just a diagnosis of exclusion. Once those criteria are met, we need to confidently name the diagnosis.
Because she swings back and forth between hard and loose stools, we've classified her as the IBS mixed subtype, and we really have to match our therapy to the specific subtype. For IBS-C, the constipation dominant, we lean on secretagogues like linaclotide or lubiprostone. For IBS-D, the diarrhea dominant, we'd go with loperamide or rifaximin. For her, along with a low FODMAP diet, we're considering a low-dose neuromodulator like amitriptyline to help reset that gut-brain axis and manage the dominant symptoms as they swing.
Of course, before cementing that IBS diagnosis, I made sure we cleared all the alarm features. She has no unintentional weight loss, no rectal bleeding, no nocturnal symptoms waking her up, and no family history of colon cancer or IBD. Since those red flags are completely absent, I held off on further invasive workups. I didn't want to fall into the trap of over-testing. Endless repeat imaging just signals to the patient that we aren't sure, and that uncertainty physically amplifies symptoms in these gut-brain disorders.
Moving on to Section 2, let's look at a couple of upper GI dysmotility problems we're consulting on, cases 2 and 3.
Case 2 is a 22-year-old man down in the ED. He came in with these severe stereotyped vomiting episodes that typically last for 2 days, but he is completely well in between them. He actually has a hypokalemic alkalosis right now from all the vomiting. History reveals daily cannabis use and a maternal history of migraines. The real clincher? The only thing that gives him relief is a scorching hot shower. So, the diagnosis? Cyclic vomiting syndrome. That hot shower relief points directly to chronic cannabis use, which is a massive driver of this syndrome.
For his ward management, we're following a strict ladder. We started with IV fluids to replete his potassium and resuscitate, plus standard antiemetics, but the true first-line targeted therapy here is actually sumatriptan. Why a migraine drug? Because the pathophysiological link between CVS and migraines is incredibly strong. If that doesn't break the cycle, we'll escalate to aprepitant for 3 days, or benzos if he's refractory, and we'll look at tricyclic prophylaxis. But the hard truth I had to tell him is that for long-term prevention, nothing is going to hold until the cannabis stops entirely.
Contrast that stereotyped vomiting with Case 3, a 56-year-old woman with type 1 diabetes. Her A1C is currently sitting at 9.4. On exam, she's got a positive succussion splash, and she's vomiting food she ate hours earlier. We scooped her, she had retained food, but absolutely no mechanical obstruction. This is classic gastroparesis. Normally the stomach's fundus relaxes, the antrum grinds up the solids, and the pylorus opens. But thanks to diabetic autonomic neuropathy, that whole system is wrecked. The fundus won't accommodate, the antral contractions are weak, and the pylorus is spastic. She gets full after 2 bites, and the food literally has nowhere to go.
To formally diagnose this, we rely on a gastric emptying scintigraphy study. The magic number to remember here is 4. The test is considered positive if solid food is still retained at 4 hours. But here is a huge clinical pearl.
If you test her while her sugars are in the 300s, or if she was on opiates, the test will just lie to you, because both independently delay emptying. For treatment, we're transitioning her to small, low-fat meals. We can try prokinetics like erythromycin or metoclopramide, though I'm always very cautious about metoclopramide given the risk of tardive dyskinesia. If she completely fails oral intake, we'll have to consider jejunal feeding.
Okay, Section 3. This is the acute colonic pseudo-obstruction case I was called about overnight. I really want us to do a deep dive here.
So here's the overnight call. It's a 79-year-old man, hospital day 4 after a hip fracture repair. He's been on scheduled oxycodone. Overnight, his abdomen massively ballooned. He hasn't passed flatus in 2 days. He's got hiccups and nausea, but notably only mild discomfort, no severe pain. On exam, he's markedly distended and tympanatic with reduced bowel sounds, but crucially, there is no rebound, no guarding, and no fever. So this is not a surgical abdomen, yet. His potassium is 3.0 and his magnesium is 1.4. The plain film shows massive colonic dilatation with gas continuing all the way to the rectum. Because there's gas in the rectum with no cutoff point, this strongly argues against a mechanical obstruction. It's Ogilvie syndrome. Unlike a small bowel ileus, which shows dilated loops and no transition point, this is massive colonic failure. The mechanism here is pure autonomic imbalance. The surgery, the pain, the critical illness, and the opiates drove a massive surge of inhibitory sympathetic outflow, while his parasympathetic drive to the distal colon just withdrew. You essentially have a flaccid colon passively filling with gas.
Now, before I left his bedside last night, there was one specific number I needed measured on that film, the cecal diameter. We have to follow this with serial films. If that cecum dilates beyond 12 centimeters, his risk of perforation skyrockets. We treat anything above 12 centimeters as incredibly high risk. If we see a rising diameter, nude tenderness, or a rising lactate, we immediately move from watchful waiting to urgent intervention.
For my assessment and plan, we started with aggressive support. I made him NPO, immediately stopped the oxycodone and any anticholinergics, and ordered replacements for his potassium and magnesium. We placed nasogastric and rectal tubes and gave methyl naltrexone since this is heavily opioid-driven. If he doesn't decompress, the next step is IV neostigmine. It works by restoring acetylcholine to kickstart that lost parasympathetic drive, but we have to be incredibly careful. It goes on a monitor with atropine drawn up at the bedside because of the risk of profound bradycardia. We'd absolutely avoid it if he had active bronchospasm or a recent bradyarrhythmia. If neostigmine fails, we'd move to colonoscopic decompression, which is for Ogilvie's only, never a small bowel ileus. And if it's completely refractory, we involve surgery for a colostomy or a colectomy.
Right. Moving down the ward to Section 4, let's look at our approach to constipation using the 4Ms framework.
Case 5 is a 68-year-old woman. She's reporting only 2 bowel movements a week, requiring severe straining and sometimes manual maneuvers. She's currently on oxycodone, calcium, and amitriptyline. When evaluating this, we really need to separate 2 distinct mechanisms. In slow transit constipation, the motility is just sluggish everywhere. Laxatives work great for that. But we also have to consider pelvic floor dyssynergia, where the pelvic muscles paradoxically contract when they should relax. The stool hits a literal wall. You can give all the laxatives you want, but they cannot fix a mechanical failure of relaxation. Those patients specifically need biofeedback therapy, not more laxatives. Before we label her with complex primary constipation, I wanted to work through the 4Ms framework to rule out secondary etiologies. First, is there a mechanical obstruction? No. Is it metabolic like diabetes, hypothyroidism, or low potassium? No. Is it a myopathy or a neurologic issue like Parkinson's? Also no. But what about medications? Yes, absolutely. She is on opioids, calcium, and a TCA. That is 3 heavy colon-slowing agents acting simultaneously. Her constipation is entirely secondary and medication-driven.
Once we identified that, we climb the management ladder. You start with fiber and docusate, then bulk agents like psyllium, and move up to stimulants like senna or osmotics like PEG. But for our patient, since she requires the oxycodone for pain, we're adding a targeted agent, a pamora like methyl naltrexone. It's brilliant because it blocks the opioid's constipating effect right at the gut receptors, while preserving the critical analgesia up in the central nervous system.
Finally, Section 5. Let's head up to the ICU and talk about nutrition in critical illness.
Our last case is a 62-year-old man, day 1 of septic shock. He is intubated and sedated, but his admin is benign. He's on a moderate but stable dose of norepinephrine. This always sparks a classic debate on teaching rounds. Should we feed this patient? And if so, how and exactly when do we start?
My plan is based on the 48-hour rule. We want to feed him enterally, using his gut, within 48 hours of admission.
Because his shock is controlled and he is on a stable, not escalating dose of vasopressors, it is a clear go. Feeding the gut is vital because it maintains the mucosal barrier, which physically prevents gut bacteria from translocating into the bloodstream and worsening his sepsis. Now, you only hold off on enteral feeding for true, absolute contraindications. Those are a mechanical bowel obstruction, major GI bleeding, or uncontrolled shock. If his blood pressure was actively crashing and his pressor requirements were climbing, feeding the gut would just increase its metabolic demand for blood flow. If its systemic perfusion can't rise to meet that local demand, we'd risk causing ischemic bowel. But again, since he's stable, we feed.
If his gut truly couldn't be used, we would wait a full 7 days before initiating parenteral nutrition, or PN. While PN bypasses the gut, it carries a high risk of central line sepsis and, most dangerously, refeeding syndrome, which is its worst metabolic complication. So to wrap up our rounds today, remember our anchors. A cecal diameter over 12 centimeters means high perforation risk. Gastroparesis means solids retained at 4 hours. Sumatriptan is first line for cyclic vomiting, and always read the medication list first. Are we treating the true underlying mechanism or just patching a symptom? Keep that question front and center. Thank you for walking through these cases with me today.